Discuss the primary differences between chronic wounds and acute wounds in terms of pathophysiology, clinical presentation, and treatment approach. Include relevant guidelines in your answer. Answer: chronic wounds and acute wounds differ fundamentally in their healing processes and underlying pathophysiology. Pathophysiology: acute wounds follow the normal stages of wound healing. Hemostasis, inflammation, proliferation, and remodeling. They typically heal within 4-6 weeks unless complications arise. Chronic wounds result from a failure to progress through the normal stages of healing, often coming stuck in the inflammatory phase due to factors such as biofilm presence, ischemia, or repeated trauma. Clinical presentation: acute wounds clean wound edges, rapid exudate reduction, minimal scarring when treated promptly. Chronic wounds: irregular wound edges, persistent exudate, potential presence of necrotic tissue, and signs of infection or biofilm. Treatment approach: acute wounds focused on wound closure through primary or secondary intention. Treatment includes debridement, if necessary, appropriate dressing, and infection prevention. Chronic wounds requires addressing underlying systemic factors, e.g., diabetes, poor nutrition. Guidelines emphasize wound bed preparation, time framework, tissue management, infection control, moisture balance, and edge advancement. Relevant guidelines: the International Wound Infection Institute (EY) stresses early detection and debridement of biofilms in chronic wounds. National Pressure Injury Advisory Panel (NPIPE) emphasizes risk factor management for pressure-related chronic wounds. Mrs. Collins, a 65-year-old patient with type 2 diabetes, presents with a non-healing ulcer on her left foot. The wound shows signs of erythema, warmth, and increased drainage. She reports poor dietary habits and occasional missed doses of her diabetes medication. What should the wound care nurse prioritize in managing Mrs. Collins' condition? Answer: the management of Mrs. Collins' condition should prioritize systemic and local factors influencing wound healing. Systemic management: optimize glycemic control. Collaborate with the healthcare team to ensure consistent blood glucose management, as hypoglycemia impairs healing by reducing neutrophil function and collagen synthesis. Nutritional support: assess and address nutritional deficiencies, providing guidance on a high-protein, nutrient-rich diet to enhance tissue repair. Local wound management: control infection. The signs of erythema, warmth, and drainage suggest possible infection. Swab cultures and empirical antibiotic therapy aligned with guidelines like those from the Infectious Diseases Society of America (IDSA) are critical. Debridement: remove non-viable tissue to reduce bacterial load and promote granulation. Dressing selection: use dressings that maintain moisture balance while protecting the wound from further trauma, e.g., foam or alginate dressings. What are the roles and limitations of the Braden scale in pressure injury risk assessment? Answer: the Braden scale is a widely used tool for assessing pressure injury risk. It evaluates 6 domains: sensory perception, moisture, activity, mobility, nutrition, and friction shear. Each domain is scored 1-4, with a lower score indicating higher risk. Roles: identifies at-risk patients for targeted interventions, facilitates early implementation of pressure redistribution devices and skin care protocols, promotes consistent documentation and communication among healthcare providers. Limitations: subjectivity: scoring can vary based on the assessor's interpretation, particularly for domains like nutrition. Population-specific variations: less predictive accuracy in certain groups, such as pediatric or bariatric patients. Focus on physical factors. Neglect psychosocial elements like mental health, which can impact compliance with preventive measures. Explain the mechanism of action and clinical applications of hydrocolloid dressings in wound care. Include their advantages and limitations. Answer: hydrocolloid dressings consist of a hydrophilic layer, carboxymethylcellulose or gelatin, combined with a hydrophobic outer layer. Mechanism of action: forms a gel-like substance upon contact with wound exudate, maintaining a moist healing environment. Promotes autolytic debridement by softening necrotic tissue. Clinical applications: ideal for shallow, moderately exudative wounds such as pressure injuries, stidgeromonum, Thurn venous ulcers. Can be used on granulating or necrotic wounds to support healing or debridement. Advantages: provides a waterproof barrier to contaminants. Minimizes pain upon removal due to its non-adhesive gel layer. Limitations: not suitable for heavily exuding or infected wounds due to limited absorption capacity and potential anaerobic bacterial growth. Mr. Patel, a 78-year-old man with limited mobility, is admitted to a long-term care facility. The staff notices a deep purple discoloration on his sacrum with intact skin. What should be the nurse's next steps, and what might this indicate? Answer: The deep purple discoloration with intact skin suggests a deep tissue pressure injury (DEI). Immediate steps: reassess the patient's risk factors using a validated tool like the Braden scale. Implement pressure offloading strategies, such as specialized cushions or mattresses. Monitor for progression to an open ulcer. Indicators and management. DTPI is caused by sustained pressure leading to ischemia and tissue damage. Early intervention aims to prevent worsening. Avoid vigorous massage or debridement as the underlying tissue damage may not yet be visible. Relevant guidelines. NPIAP advises classifying DTPI accurately to guide care and prevent complications. How do systemic factors like diabetes and malnutrition influence wound healing? Discuss these effects in terms of cellular and molecular mechanisms. Answer: systemic factors such as diabetes and malnutrition profoundly impact wound healing, primarily by altering cellular and molecular mechanisms involved in tissue repair. Diabetes, impaired immune function. Hyperglycemia impairs neutrophil and macrophage function, leading to an inadequate immune response to infection. Alter collagen synthesis. Elevated blood sugar levels impair fibroblast function, reducing collagen production and slowing the formation of the extracellular matrix (ECM), which is crucial for tissue repair. Increased risk of infection. Elevated glucose levels create a favorable environment for bacterial growth, increasing the likelihood of wound infection. Vascular complications. Diabetes can lead to microvascular damage, reducing oxygen and nutrient supply to the wound site, further delaying healing. Malnutrition. Protein deficiency. Protein malnutrition compromises the synthesis of collagen and other ECM proteins, weakening the wound structure and delaying closure. Deficient micronutrients. Zinc, vitamin A, and vitamin C deficiencies impair various stages of wound healing, such as collagen synthesis and epithelial cell proliferation. Delayed inflammation resolution. Nutrient deficits extend the inflammatory phase, preventing the timely transition to the proliferative phase. Relevant guidelines. The American Diabetes Association (ADA) emphasizes optimal glucose control in managing diabetic wounds to enhance healing. Clinical practice guidelines from the Wound Healing Society recommend addressing nutritional deficits to optimize wound healing with specific attention to protein and micronutrient intake. Mr. Rogers, a 55-year-old obese patient with a history of smoking and hypertension, presents with a stage 2 pressure injury on his heel. He is non-compliant with repositioning and has a BMI of 35. What interventions should the wound care nurse prioritize for this patient? Answer: Mr. Rogers' stage 2 pressure injury requires immediate intervention to promote healing and prevent further deterioration. Pressure redistribution, repositioning. Encourage repositioning every 2 hours to offload pressure from the affected heel. This is critical to avoid progression to deeper tissue injury. Specialized mattress and cushions. Recommend a pressure-relieving mattress and heel protectors to reduce pressure on vulnerable areas. Management of comorbidities. Smoking cessation. Provide resources for smoking cessation as nicotine impairs circulation and collagen synthesis, delaying wound healing. Blood pressure control. Ensure optimal management of hypertension as poor circulation can hinder wound healing. Nutritional support. Dietary consultation. Refer the patient to a nutritionist to assess for any nutritional deficiencies, particularly protein and vitamin C, and recommend a high-protein, micronutrient-rich diet. Wound care. Appropriate dressing. Apply dressing that promotes a moist wound environment and allows for autolytic debridement, such as hydrocolloid or foam dressings. Relevant guidelines. The National Pressure Injury Advisory Panel (NPIAP) stresses the importance of early intervention, including repositioning and proper nutritional support in preventing pressure injury progression. Wound Healing Society guidelines emphasize addressing systemic factors such as smoking and obesity in chronic wound management. What is the role of moisture balance in wound healing, and how can excessive moisture negatively impact the healing process? Answer: moisture balance plays a crucial role in wound healing by maintaining an optimal environment for cell migration, collagen synthesis, and tissue granulation. However, both dryness and excess moisture can hinder the healing process. Moisture in wound healing promotes cell migration. A moist environment facilitates the migration of epithelial cells across the wound bed, speeding up reepithelialization, reduces pain. Moisture helps minimize the nerve exposure, reducing pain during dressing changes. Excess moisture associated with wound exudate, maceration. When a wound becomes too wet, surrounding skin may soften and break down, a condition known as maceration, which leads to delayed wound closure and increased infection risk. Infection risk. Excess moisture can also provide an ideal environment for bacterial growth, increasing the risk of infection. Managing moisture. Absorbent dressings. Use dressings that absorb excess exudate, e.g., alginates, foam dressings, while maintaining moisture balance. Barrier creams. Apply barrier creams to protect surrounding skin from maceration when dealing with high exudate wounds. Relevant guidelines. WOCN, Wound Ostomy and Continence Nurses Society, provides clear guidelines on selecting moisture-retentive dressings based on wound exudate levels. European Wound Management Association (EWMA) emphasizes the importance of moisture balance to optimize healing while minimizing complications like infection or maceration. How do biofilms contribute to chronic wound infections, and what are the current best practices for managing wounds with suspected biofilm presence? Answer. Biofilms are structured communities of bacteria encased in a self-produced extracellular matrix. They play a significant role in the chronicity of wound infections by impairing the body's ability to eliminate pathogens and delaying healing, formation, and impact. Impaired immune response. Biofilms prevent immune cells like neutrophils from accessing the bacteria, effectively hiding the infection. Antibiotic resistance. Bacteria within biofilms are often more resistant to antibiotics, contributing to persistent infections and delayed healing. Chronic inflammation. The persistent presence of biofilms can prolong the inflammatory phase of wound healing, preventing progression to the proliferative phase. Management of biofilm-associated wounds. Debridement. Mechanical or enzymatic debridement is essential for removing biofilm layers and allowing better access to the wound bed. Antibiotic therapy. Use appropriate antibiotics based on wound cultures and sensitivity testing, and consider biofilm targeting agents such as honey or silver. Biofilm disruption. Emerging treatments like ultrasound or low-frequency electromagnetic therapy show promise in disrupting biofilm structure and enhancing antibiotic efficacy. What are the primary considerations when selecting a pressure-relieving device for a patient with a high risk of pressure injuries? Discuss different types of devices and their indications. Answer. The selection of pressure-relieving devices is crucial for preventing pressure injuries, especially in patients with high risk. The primary considerations include the patient's risk level, mobility, skin condition, and exudate levels. Types of pressure-relieving devices. Pressure-relieving mattresses. Foam mattresses provide support and redistribute pressure, ideal for low-risk patients. Alternating pressure mattresses. Suitable for moderate to high-risk patients as they alternately inflate and deflate to relieve pressure. Low air loss mattresses provide a constant flow of air to keep the skin dry and are best for high-risk patients with moderate to heavy exudate. Indications. Foam mattresses, appropriate for patients with low to moderate risk of pressure injury. Alternating pressure mattresses, ideal for patients with high risk or existing pressure injuries. Low air loss mattresses, used for patients with high moisture levels or heavy exudate, especially those with existing wounds. Explain how hypoglycemia contributes to the development and persistence of diabetic ulcers. Include the roles of neuropathy, ischemia, and infection in your answer. Answer. Hypoglycemia contributes to diabetic ulcers by impairing multiple systems. Neuropathy. Chronic hypoglycemia leads to damage in peripheral nerves. Diabetic neuropathy. This results in sensory loss, making patients unable to detect injuries or pressure points. Over time, repetitive trauma occurs without intervention. Ischemia. Hypoglycemia damages endothelial cells, reducing nitric oxide production and impairing vasodilation. Coupled with arteriosclerosis, thickening of arterial walls, this reduces oxygen and nutrient supply to tissues, delaying wound healing. Infection. High glucose levels support microbial growth. Additionally, hypoglycemia impairs leukocyte function, reducing the immune response. This increases susceptibility to infections that can exacerbate ulcers. Relevant guidelines. International Working Group on the Diabetic Foot (IWGF) Guidelines. Stress early detection and management of neuropathy and ischemia. Discuss the contraindications for compression therapy in venous ulcers and the recommended protocol for assessment prior to its initiation. Answer. Compression therapy is contraindicated in patients with severe arterial insufficiency, e.g. ankle brachial index AB 0.5, as it can further reduce blood flow to ischemic tissues. Protocol for assessment. ABI measurement. A key diagnostic tool to assess arterial blood flow. ABI between 0.5 and 0.8 warrants cautious use of modified compression. Doppler ultrasound, used to confirm arterial or venous conditions. Skin integrity examination, ensure no necrosis or signs of active infection that compression may exacerbate. Relevant guidelines. Wound Ostomy and Continence Nurses Society WOCON recommends compression as the standard of care for venous ulcers provided arterial flow is adequate. Mr. Davis, a 52-year-old diabetic patient, reports swelling, redness, and warmth in his left foot without any clear injury. He has no pain due to diabetic neuropathy. An X-ray reveals joint disorganization. What is the most likely diagnosis and how should this condition be managed? Answer: the most likely diagnosis is Charcot foot, a serious complication of diabetic neuropathy. Charcot foot occurs when nerve damage reduces sensation in the feet, leading to unrecognized injury, inflammation, and bone damage. The absence of pain is typical due to neuropathy, and the X-ray findings of joint disorganization support the diagnosis. Management includes offloading. The primary treatment involves offloading pressure from the affected foot using total contact casting (TCC) or specialized orthotic devices. This helps prevent further joint deformities and fractures. Monitoring and imaging. Regular X-rays or MRIs are needed to track progression and ensure proper healing. Blood sugar control. Strict glycemic control is essential to prevent further nerve damage and worsening of the condition. Surgical intervention. In some cases, surgery may be necessary to correct deformities or improve function if non-surgical methods fail. Explain the diagnostic steps and treatment priorities for arterial ulcers. Why is revascularization critical? Answer: diagnosis of arterial ulcers begins with a physical exam where ulcers are often located on pressure points, e.g., toes or heels. The skin is typically pale, thin, and shiny, and there may be hair loss. The next step is to perform ankle brachial index ABI testing. An ABI of less than 0.9 suggests arterial insufficiency. If ABI is low, Doppler ultrasound or angiography may be used to assess blood flow and pinpoint the level of blockage. Treatment priorities include revascularization. This is crucial because restoring blood flow is the key to healing. Surgical options like angioplasty or bypass surgery can help restore circulation to ischemic tissues. Wound care. Focus on moist wound healing and managing exudate, but avoid aggressive debridement, which can worsen ischemic damage. Risk factor management. Control of hypertension, hyperlipidemia, and smoking cessation is vital to prevent further arterial damage. Revascularization is critical because without improved blood flow, healing is unlikely and the risk of gangrene increases, potentially requiring amputation. Identify 5 key components of patient education to prevent diabetic foot ulcers. Why is each component critical? Answer: 5 key components are daily foot inspection. Regular inspection helps catch early signs of injury or infection before they escalate. Proper footwear. Well-fitted shoes prevent pressure points and blisters, reducing the risk of trauma. Avoid barefoot walking. Walking barefoot increases exposure to cuts, punctures, or infected wounds, which could lead to ulcers. Skin moisturization. Keeping the skin hydrated prevents cracking and dryness. The moisture between toes should be avoided to prevent fungal infections. Blood sugar control. Glycemic control is essential to prevent nerve damage, which can reduce the ability to feel injuries and impair healing. These components are critical because proper foot care can prevent the onset of diabetic ulcers, limit complications, and reduce the likelihood of serious infections or amputations. Compare the roles of neuropathy and ischemia in the development of diabetic ulcers. How does their coexistence complicate treatment? Answer: neuropathy and ischemia both contribute significantly to the development of diabetic ulcers. Neuropathy impairs sensation, preventing patients from feeling pain or injury, which increases the risk of unnoticed trauma. Ischemia, on the other hand, reduces blood flow to the tissues, impeding the delivery of oxygen and nutrients necessary for wound healing. When both conditions coexist, treatment becomes more complex. Neuropathy may mask the symptoms of ischemia, causing delayed detection of circulatory issues. Furthermore, ischemia reduces the effectiveness of wound healing as the tissues are deprived of essential nutrients. Without sufficient blood flow, even small wounds may not heal, making infection more likely. In such cases, wound care must address both impaired circulation and nerve dysfunction. Interventions like revascularization and offloading are necessary, while strict glycemic control is critical to prevent further progression of both neuropathy and ischemia. Relevant guidelines. American Diabetes Association (ADA) emphasizes the need for comprehensive management of both conditions to prevent ulceration. Why is maintaining an optimal wound environment crucial in managing chronic ulcers? Discuss the principles of moist wound healing. Answer: maintaining an optimal wound environment is essential for promoting healing and preventing complications like infection. The goal is to create an environment that supports tissue regeneration and prevents desiccation or maceration. Principles of moist wound healing. Hydration. A moist environment accelerates the proliferation of fibroblasts and epithelial cells, speeding up the healing process. Exudate management. Excess exudate should be absorbed without causing skin maceration. Debridement. Dead or necrotic tissue should be removed to prevent infection and promote healthy tissue growth. Moist wound healing prevents the formation of scabs, which can hinder cell migration and healing. It also maintains a balanced temperature, which supports the function of enzymes involved in tissue repair. Relevant guidelines. National Pressure Injury Advisory Panel (NPIP) recommends moist wound healing for most chronic ulcers. Distinguish between pressure ulcers and venous ulcers in terms of pathophysiology, appearance, and treatment. Answer. Pressure ulcers develop due to prolonged pressure on the skin, typically over bony prominences, reducing blood flow and causing tissue necrosis. They are often seen in immobile patients and have well-defined edges, with a necrotic center and surrounding erythema. Treatment includes pressure relief, wound debridement, and nutritional support. Venous ulcers, on the other hand, are caused by chronic venous insufficiency where poor venous return leads to stasis of blood in the lower extremities. These ulcers are usually located on the medial malleolus and have irregular borders, with a reddish-brown discoloration due to hemosiderin deposition. Compression therapy is the cornerstone of treatment to improve venous return, along with wound care and elevation of the legs. In summary, pressure ulcers result from external pressure, whereas venous ulcers are due to internal circulatory dysfunction. Treatment strategies differ, with the focus on pressure relief for pressure ulcers and compression for venous ulcers. Relevant guidelines. European Pressure Ulcer Advisory Panel (EPUAP) advocates for early intervention and pressure redistribution techniques. Discuss the primary risk factors for diabetic foot ulcers and the preventative strategies to mitigate these risks. Answer. Primary risk factors for diabetic foot ulcers include poor glycemic control, neuropathy, peripheral artery disease, PAD, and previous foot ulcers. High blood sugar levels contribute to neuropathy, reducing sensation, while PAD impairs circulation, hindering wound healing. Previous ulcers increase the likelihood of recurrence due to scar tissue and compromised tissue integrity. Preventative strategies include glycemic control. Tight control of blood glucose helps prevent neuropathy and vascular complications. Foot care education. Regular inspection and proper footwear are essential to detect early signs of injury. Smoking cessation. Smoking exacerbates PAD and reduces circulation, so quitting is critical. Regular foot exams. Regular exams by healthcare providers to detect changes in foot health. Relevant guidelines. American Diabetes Association (ADA) recommends annual foot exams and individualized prevention plans. Outline the approach to managing infected chronic ulcers. What are the key principles of wound infection control? Answer. Infected chronic ulcers require a systematic approach that begins with identifying the type of infection, followed by appropriate treatment. The first step is to clean the wound to remove debris and debride necrotic tissue to enhance healing. Culture and sensitivity tests help identify the causative pathogens, guiding antibiotic therapy. Key principles of wound infection control. Antibiotic therapy. Empirical antibiotics are given based on the infection severity, followed by targeted therapy based on culture results. Moist wound healing. This environment promotes healing and protects against further contamination. Offloading and pressure relief. These prevent further tissue damage, allowing for better healing. Managing infection is critical to prevent sepsis or gangrene, which can lead to amputation. Explain the critical factors influencing the healing of surgical wounds and how delayed wound healing could be minimized postoperatively. Answer. Surgical wound healing is influenced by several key factors. Patient-specific factors, age, comorbidities, e.g. diabetes, obesity, and nutritional status significantly impact healing. Diabetes delays collagen synthesis and reduces immune function. Surgical technique. Proper tissue handling, avoiding excessive tension, and minimizing ischemia reduce trauma and infection risks. Infection prevention. Prophylactic antibiotics based on CDC guidelines. Proper aseptic technique and sterile dressings are essential. Nutrition. Adequate protein intake, vitamins and C and minerals like zinc promote tissue repair, minimizing delayed healing. Wound care. A moist environment promotes faster healing and reduces scarring. Infection control. Regular wound assessments for signs of infection, e.g. erythema, discharge. Patient education. Address smoking cessation, glycemic control, and adherence to care instructions. Discuss the risk factors for surgical wound dehiscence and evidence-based interventions to prevent this complication. Answer: dehiscence or wound reopening is most commonly caused by increased pressure. Conditions like obesity, vomiting, or constipation increase intra-abdominal pressure, leading to stress on sutures. Poor technique, incorrect suturing, inappropriate tension, or poor closure can cause wound dehiscence. Comorbidities: diabetes, malnutrition, immunosuppression, and prolonged corticosteroid use impair collagen formation and immune responses, leading to delayed healing. Prevention strategies: patient optimization. Manage comorbidities like diabetes with tight glycemic control, 8018-year-DL, and optimized nutrition. Surgical technique: employ retention sutures for high-risk patients, ensuring adequate tissue approximation. Postoperative care: minimize strain on the incision by using abdominal binders, avoiding heavy lifting, and managing constipation. Regular monitoring for early signs of infection or failure to heal is crucial. Mrs. Carter, a 62-year-old diabetic, underwent a fasciocutaneous flap procedure to cover a chronic wound. On the third postoperative day, the nurse observed slight discoloration and reduced capillary refill in the distal portion of the flap. What should be the next steps in her care, and why? Answer: Mrs. Carter is likely showing signs of flap ischemia, which can occur when blood supply to the flap is compromised. Immediate steps include: assess the flap, check for color changes, temperature, and capillary refill, loosen dressings. Tight dressings may compromise circulation, so they should be loosened to relieve pressure. Consult with the surgeon. Notify the surgical team for potential intervention, such as surgical revision or adjusting flap sutures. Monitor regularly. Check the flap's perfusion status every 2-4 hours and document changes. Ischemia can lead to flap necrosis if untreated, making early intervention crucial. In diabetics, compromised vascular function increases the risk, so prompt evaluation is essential for salvage. By carefully monitoring the flap and involving the surgical team, you can improve the chances of salvaging the flap and avoid further complications. Describe the pathophysiology of surgical site infections and outline a comprehensive plan for their prevention based on current guidelines. Answer: surgical site infections occur when bacteria invade the surgical wound, forming biofilms that delay healing. The most common pathogens are Staphylococcus aureus and Escherichia coli. Once bacteria gain entry, they multiply and cause inflammation, leading to delayed healing, pain, and potential systemic infection. Prevention plan: preoperative, patient optimization, correct comorbidities, ensure proper nutrition, protein, vitamins, minerals. Aseptic technique: shower with antimicrobial agents, hair removal using clippers. Antibiotic prophylaxis: administer broad-spectrum antibiotics within 1 hour of incision based on CDC recommendations. Intraoperative: use sterile technique throughout surgery. Maintain normothermia. Maintaining a temperature above 36 degrees reduces infection risk. Limit surgical time and tissue handling. Postoperative: monitor for signs of infection, redness, swelling, pus. Ensure proper wound care and dressing changes. If infection develops, collect wound cultures and initiate appropriate antibiotics. By following these guidelines, the risk of SSI can be significantly minimized, ensuring faster recovery and better outcomes. Discuss the mechanism of MPWT and its specific contraindications in wound care management. Answer: mechanism: NPWT applies subatmospheric pressure to the wound via vacuum-sealed dressing. This negative pressure removes exudate, reduces fluid accumulation, preventing maceration and promoting a clean wound bed, stimulates granulation tissue formation. The mechanical force encourages cell proliferation and matrix deposition, enhances perfusion. Negative pressure increases blood flow to the wound area, promoting tissue repair. Contraindications: active infection. In cases of untreated osteomyelitis or necrotizing fasciitis, NPWT may worsen the infection. Exposed structures. NPWT should not be used over exposed organs, blood vessels, or nerves, as it may cause further damage. Malignant wounds. Wounds with underlying malignancy should not undergo NPWT due to potential spread of cancer cells. Differentiate between partial thickness and full thickness burns in terms of clinical presentation, pathophysiology, and management. Answer: partial thickness burns. Presentation: red, moist, blistered, painful, with intact capillary refill. Pathophysiology: involves the epidermis and part of the dermis. The dermal appendages remain intact, which allows for regeneration. Management: debridement, application of topical antimicrobial agents and moist wound dressings to promote healing. Full thickness burns. Presentation: dry, leathery, or charred appearance with no pain. Nerve destruction. Pathophysiology: involves complete destruction of the epidermis, dermis, and subcutaneous tissues. Healing occurs through grafting. Management requires surgical excision of necrotic tissue followed by skin grafts. Pain management is crucial due to the absence of nerve endings. Both types of burns require fluid resuscitation, pain management, and monitoring for complications like infection and hypovolemia. Explain the principles of topical antimicrobial therapy and burn wound care and provide examples of agents used. Answer: topical antimicrobial therapy helps prevent infection, which is a major complication in burn care. Principles: broad spectrum coverage. Burn wounds are prone to infection from both gram-positive and gram-negative organisms. Non-cytotoxic. The antimicrobial agents should not harm the healing tissue. Moist environment. Moisture retention accelerates healing and reduces pain. Examples: silver sulfadazine, effective against a wide range of bacteria and fungi, but it may cause skin discoloration and delayed wound healing. Mayfonide acetate, broad spectrum but can cause metabolic acidosis and stinging on application. Honey, a natural antimicrobial with anti-inflammatory properties, often used in the treatment of superficial burns. What are the main principles of scar management in burn patients, and what are the key interventions to improve outcomes? Answer: scar management is critical in burn patients to enhance function and aesthetics. Early mobilization prevents joint contractures and maintains flexibility. Pressure garments applied after wound closure to reduce hypertrophic scarring by applying consistent pressure. Silicone gel sheets used to reduce scar formation and improve the cosmetic appearance of scars. Laser therapy, used for scar remodeling, reducing pigmentation, and softening the scar. A multidisciplinary team approach, including physical therapy, occupational therapy, and psychological support, is essential for optimizing long-term recovery and quality of life. Describe the psychological challenges faced by burn patients during rehabilitation and the strategies for addressing them. Answer: burn patients often experience significant psychological challenges, including post-traumatic stress disorder, PSD, anxiety, and depression. The changes in physical appearance, loss of independence, and prolonged hospitalization can exacerbate these issues. Strategies: psychological counseling. Providing mental health support through individual or group therapy helps patients process trauma. Social support. Involving family and friends in the rehabilitation process improves emotional well-being. Pain management. Addressing physical discomfort reduces stress and enhances participation in therapy. Self-esteem enhancement. Rebuilding self-image through rehabilitation and cosmetic interventions helps patients regain confidence. Addressing both physical and psychological recovery ensures holistic care, improving both quality of life and functional outcomes. How does nutritional support influence the recovery of burn patients, and what are the key components of a burn-specific diet? Answer: nutritional support plays a crucial role in burn recovery as it aids in tissue repair, immune function, and overall recovery. Burn injuries increase metabolic demands due to the inflammatory response, requiring an increase in caloric intake to promote healing. Key components of a burn-specific diet: calories. Increased caloric intake is needed to meet the hypermetabolic state induced by burns. The Curry formula is commonly used to estimate calorie needs based on body weight and extent of burns. Protein. Adequate protein intake is essential for wound healing and immune function. Protein should account for a significant portion of the caloric intake, with recommendations typically ranging from 1.5 to 2.5 grams of body weight per day. Micronutrients. Vitamins A, C, and zinc are crucial for collagen synthesis and immune function, and should be supplemented if deficiencies are suspected. Fluids. Proper hydration is vital to replace lost fluids and maintain circulatory volume. Early and continued nutritional intervention significantly reduces the risk of complications like wound infection and contributes to better healing and quicker recovery times.